So emerging data of the type I was just mentioning suggested that fibromyalgia may have pathophysiological subgroups that could potentially be distinguishable on the basis of clinical neurochemical or neuroendocrinological abnormalities. And so this is where the field is going to go, I think, in the next 10 years, is to say that fibromyalgia, or the broader category called chronic widespread pain, is not one disorder, it's many disorders. And each person who has it has potentially one or multiple different pathophysiological predilections or processes that are driving the pain. And some of this is going to end up being understandable in terms of genetic polymorphisms. For example, here's a study that looked at COMT polymorphisms and found that fibromyalgia patients were much more likely to have one type of genotype than the general population. So some of the categorization of fibromyalgia into groups is going to be based on genetic profiling, and some of it may be based on neurochemical changes that presumably have a genetic profile, but no one's ever going to figure it out. For example, patients with high substance P in the CSF may reflect a group with a hyperalgesic response in peripheral nociceptors that drive central sensitization for reasons that are unclear. But ultimately, it's all genetic at some level. But the bottom line is that some of these genetic subtypes will be discovered before others. Okay, so fibromyalgia is a disease of chronic pain, chronic widespread pain, and it typically presents to you all and to me as a syndrome. And the syndrome of fibromyalgia is the constellation of chronic widespread pain associated with medical and psychiatric comorbidities. And that's one of the ways that you make the diagnosis of fibromyalgia. If someone presents with a chronic widespread pain syndrome, a history and an examination may identify comorbidities that point to this constellation that's common in that population. So for example, chronic fatigue occurs in 21 to 80% based on different studies. Irritable bowel syndrome, very common. TMJ disorder, very common. Headache, very common. Multiple chemical sensitivities, interstitial cystitis, and chronic pelvic pain of unknown etiology, all common. Interestingly enough, there are syndromic constellations that will get labeled by different diagnoses depending on what predominates clinically and who the patient sees. So for example, if you take the population with chronic fatigue syndrome and people who have been diagnosed as having CSF, and you survey them for pain prevalence, you find out that about 80% of them have pain, but they're diagnosed as CFS. If you go to a fibromyalgia population who have sought out help for pain, you find that about 80% are fatigued. If there's another disorder called multiple chemical sensitivities disorder, also felt to be psychiatric in the past and now sort of moving to something that's not psychiatric. Not really known what that is, but patients with multiple chemical sensitivity disorders, often diagnosed by going to allergists or going to general internists, these patients will have a high prevalence of fatigue and a high prevalence of body pain. And finally, patients who have major depressive disorder. Chronic pain and major depressive disorder and fatigue are two of the cardinal symptoms that patients get. So if you say major depressive disorder, multiple chemical sensitivities disorder, fibromyalgia, and chronic fatigue syndrome, in my mind, this is a big Venn diagram with a large set of intersections. And so when a patient comes to me, for example, and says, I have pain, I may, from the clinical perspective, try to reframe what this patient's experiencing into a problem that's mostly fatigue, or fatigue and pain, or mood disturbance and pain, in an effort to try to identify what the key targets for the treatment will be. This just actually happened last week. I did a consultation on a person who had multifocal pain, didn't meet the criteria for fibromyalgia, and I made the diagnosis of chronic widespread pain, which the patient actually had heard of on the web, had read about on the web, and they said, well, what does that mean? And I said, it just means you have pain you don't have fibromyalgia, you have pain, you have chronic widespread pain. It's a syndrome that's being recognized more and more by pain specialists. But really, your biggest issue today is your fatigue syndrome. And when I said that, it was like a light bulb went off, and the patient said, you are so right. I'm sitting in the chair all day. It's not because I have too much pain to get up. I'm just too tired. And so by reformulating, by reframing the syndrome for that person, there was a new way of going forward therapeutically. I don't know if it's going to help her, but it was a new way of going forward. Because she had been just seeking out pain treatments, lots of injections, lots of medicines. But the answer for her to get better, have a better quality of life, was probably focused, at least right now, on fatigue. So these are the comorbidities. When you see somebody who has chronic widespread pain, ask about fatigue and IBS and headache syndromes. Major depressive disorder, very common. Anxiety, also very common. So let's just talk about the diagnosis of fibromyalgia. You notice that I didn't put this first, and the reason I didn't put this first is because in the past, it was common for people who were knowledgeable to get hung up on the box that was called the diagnosis of fibromyalgia based on the ACR criteria that were published in 1990. And subsequently, and I must tell you that, I've never really bought into this. And I'm not sure if it was because I'm sort of a negativistic guy to begin with, or because my experience clinically didn't support it. But I was very, very happy when there was a term chronic widespread pain that got promoted as a broader diagnosis, because the patients would come to me when I was doing more of a pain practice, and they'd have multifocal pain, but they didn't have multiple tender points. They didn't meet criteria for fibromyalgia, so they had literally no diagnosis. And having no diagnosis in an area where psychiatric disorder is assumed to be the major problem is a bad thing for a patient. They get immediately stigmatized. At least if they had a diagnosis of fibromyalgia in the past, some doctors were sort of more willing to say, well, maybe there's something there biologic. You're probably crazy, but maybe there's something biologic. But when they couldn't even have the diagnosis of fibromyalgia, then all bets were off. They just got stigmatized as, women who were distressed and had pain. So that's one of the reasons I want you to know about the ACR criteria. And if you encounter patients with chronic pain, do an examination to see whether or not you can diagnose them as fibromyalgia. But you don't need to diagnose. You don't need to find the criteria to develop a treatment strategy for chronic widespread pain. You don't need to find these criteria. So these are the criteria from the ACR. 3 months or more of chronic widespread pain, left and right sides of the body, above and below the waist, and in the axial skeleton, and tender points in at least 11 of 18 spots. Does everybody know the difference between a tender point and a trigger point? So a trigger point, a tender point, is an area that elicits pain with very, very limited pressure. If you press on your nail enough to blanch it, that's the pressure you should be using to assess the existence of tender points. So, I've been in the room with clinicians who would go up to a patient and take a thumb and push it 3 inches into the body and say, does that hurt? And when the person said yes, they say, well, they got tender points or trigger points. Tender points are elicited with very, very minimal pressure, just the amount that it takes to blanch a nail. Trigger points are also elicited with pressure, but they historically are understood to be in muscle in association with what's called a taut band. There's a sign where if you run your finger perpendicular to the length of the muscle, you run over the muscle band that has the trigger point and elicit pain. And probably most importantly, trigger points, if you inject them, can disappear, or if you even just dry needle them, they can disappear. Tender points don't disappear. At least not in a prolonged way. You can make anything disappear if you anesthetize the whole area around it, but they come back. So how this got done in the late 1980s I have no idea, but it was a very large observational study, and a consensus group at the ACR chose this number, right? So it was the rheumatologist choosing a number, and based on clinical experience and an observational study. And the tender points that they chose, you can see, I don't think I have a graph of it here. But the tender points, if you go on the web or look in a pain textbook, their tender points are occipital and clavicular head, and between the scapula and elbow and knee, greater trochanter, lumbar region. And again, I don't make a point of exploring all 18 tender points routinely, because it doesn't matter. It used to matter, it doesn't matter anymore. If a person has tender points in that area, in these areas, as well as in other areas or not, but they're in these areas and they have chronic widespread pain that is both left and right, up and down, you can call them fibromyalgia. If they don't have that, you can say probable fibromyalgia, or you can use this term now that's more accepted, chronic widespread pain syndrome. And chronic widespread pain syndrome gets you to the same place therapeutically.